Greetings, my name is Lindsay Ma and I'm a rising intern in internal medicine. Today we'll be talking about pneumonia and specifically focusing on how to diagnose and initially manage community-acquired pneumonia, or CAP. The target audience for this talk is medical students, clerkship level or higher, and let's see what we can learn today. So patients with pneumonia can present with mild symptoms like cough or develop severe complications such as respiratory distress and sepsis. Although pneumonias are divided into three camps based on how they are acquired, today we will focus on CAP. We know that in VA emergency rooms, community-acquired pneumonia is both under and overdiagnosed due to its symptoms overlapping with many other heart and lung diseases. So, as clinicians, this means we have room to grow in terms of recognizing what is and is not CAP. So, let's talk about how to diagnose and treat CAP. To start, what is pneumonia in a physiologic sense? Usually, I define pneumonia as infection of the alveoli, which ultimately leads to things like inflammation and some other consequences. It also has to be less than 48 hours since admission to be specifically community-acquired pneumonia. All right, so moving on to history, what would make you concerned that your patient has CAP? Well, they might have infectious signs such as fever. There can be lung-specific symptoms such as dyspnea, cough, and change in sputum production or quality. We also want to know the onset. Has it been going on for weeks, or has this started in the last few days? And lastly, we always want to ask about exposures, which could predispose the patient to developing pneumonia, like a sick contact. And another would be immunodeficiency. Maybe the patient's on immunosuppressing medications or has cancer to begin with. And then we'll do an exam. The most important exam here is the pulmonary exam. Although none of the exam findings we're about to talk about have great positive predictive value or negative predictive value, the ones that we do still look for include tachypnea, hypoxemia, increased work of breathing, and crackles on auscultation. You also might find signs of consolidation, such as like dullness to percussion, but this can be hard to appreciate sometimes. After you've taken their history and exams, we almost always get some labs. In this case, what are the two labs that you would think about getting for this patient? The first would be a CBC, and this is to help assess for any leukocytosis. So high white blood cell count would be concerning for some type of inflammatory picture, whether that be an infection or not. And we'd also want to get a CMP. This one's interesting because it doesn't tell us directly about whether there's an infection, but if there is elevated creatinine, elevated BUN, this tells us that the kidneys are not working very well, and that makes our prognosis worse. Also, if LFTs are elevated, and there's some transaminase elevations, then we could be more suspicious for a septic picture. which would also make us more likely to admit this patient. And we have a separate talk talking more about sepsis, so I will leave it at that. What is the one imaging modality that we think of when we are concerned about pneumonia? In my book, it's a chest x-ray. And what are you looking for on that chest x-ray? Well, I think we can think about it in 3 buckets. We want to think about things that will help us rule in pneumonia. We want to think about stuff that helps us diagnose things other than pneumonia. And complications of pneumonia. For ruling in pneumonia, things we're looking for are opacities that make us think that there is infiltrates. And then complications of pneumonia could include a parapneumonic effusion, pleural effusion, could be an empyema, for example. And then some things that would present with a history and exam that sound like pneumonia could be things like heart failure and malignancy. So patients who have a heart failure exacerbation or a growing malignancy might have pneumonia at the same time, but they also might not have pneumonia at all, and they might just have these conditions instead. So if your history, exam, labs, and imaging are kind of making you suspicious for community-acquired pneumonia, then we have 2 things to do. The first is to get some extra labs, and then we'll want to start antibiotics. So there are 6 microbiome tests that are important to get. Well, the first thing to get would be blood cultures. We want 2 of them, and they should be peripheral blood cultures, and can ultimately help us narrow antibiotics down the line. We also want to get a sputum and do gram staining, as well as culture. Unfortunately, only like 20% of pneumonia cases do we even identify a bug, but this is still routinely done because on the off chance that you can identify a bug, this would help, again, narrow antibiotic choices so that you're not using too broad of an antibiotic for the pathogen that is of concern. The other thing with the sputum is that this cough really has to be from like the deep portions of the lung to be a helpful sample. A lot of the times patients will just spit up whatever they have kind of in the upper airway, and that can just be a bunch of different colonizing bacteria and organisms that really don't have anything to do with this patient's infection. Okay, another one is to get urine strep pneumo. Oops. We also want urine Legionella. And then we'll want to get something to help rule out viral causes of pneumonia, which are possible. So we'll get viral PCR. This can be just COVID and flu, or it could be a full respiratory panel. Depends on your level of suspicion, and it can depend on the patient's exposures, the time of year, whether it's flu season or not. So you can kind of adjust how broadly you go with this viral workup based on your patient. And then plus minus on an HIV screen in order to determine underlying immunodeficiency. Some patients might already have a recent HIV test for whatever the reason, and so if that's negative, you may not have to do this again. But if you have other signs or symptoms concerning for immunodeficiency, then this could be a really high-yield test to get. Those labs will take anywhere from, 20 minutes to come back to days. And so We'll want to start empiric antibiotics. So let's talk about those. The empiric antibiotics are always decided based off of what bugs are most likely to be causing the infection. In this case, what bug comes to mind as the most likely cause for pneumonia in, let's say, an adult with no immunodeficiencies who hasn't been admitted to the hospital in the last couple years? The one we'd be worried about is strep pneumo. And I'll put it in purple since it's a gram-positive organism. The medication that we'd want to use for strep pneumo is some type of beta-lactam. An example would be ceftriaxone. And then there is actually a second antibiotic that we give at this time, and it would be a macrolide. Interestingly, it's not for its antimicrobial properties, but rather azithro will help us manage some of the cytokines that are activated and result to this infection. All right, so to recap, community-acquired pneumonia occurs when a patient has infection of their alveoli, and that this happens when they're home or before 48 hours of admission to the hospital. This is distinct from ventilator-acquired pneumonia and hospital-acquired pneumonia. History can be helpful, and they may have lung symptoms like cough and dyspnea, and perhaps even fever. It's important to assess for predispositions, and their exam can be useful but is not definitive in determining whether a patient has CAP. Basic labs should include a CBC and CMP, and imaging should include a chest X-ray. The basic labs will help determine how severe the infection is and whether this patient might need an admission. If your suspicion for CAP is present and you've already gotten your imaging, you'll want to get some extra microbiome labs, and we discussed the 6 labs to get. And once those labs are drawn, you'll want to start empiric antibiotics with the beta-lactam and macrolide to help cover this patient until you're certain what bug is causing the infection and can narrow. And as we talked about, only 20% of the time is an organism isolated. And so the patient will very likely have to continue on with these broader spectrum antibiotics until their course is complete. Things not covered in this talk are how to determine the severity of the pneumonia, which will influence whether the patient is sent home for outpatient treatment, admitted to a general medicine floor, versus admitted to the ICU. We also don't discuss here how to narrow the antibiotics and when to cover some resistant organisms like MRSA and Pseudomonas. So feel free to read up on these on your own, or let me know if it would be helpful to have a separate talk for these items. Your time is precious, so thanks again for joining me for this talk. Until next time.